Okay. Good. All right, great. So we're going to go ahead and get started. This is a talk about cancer. Really, very terrible disease. I think it affects a lot of people or someone often someone you know. Um, this is not really necessarily about treatment of specific cancers. So I'm really going to talk just generally about what cancer is. Again, primary care. So from a primary care perspective, what is it? What should we care about? What can we do? What are symptoms? What are some different types of common cancers? Maybe some other cancers, uh, a few other things. So with that, we'll just get right into the next slide here. So just quick disclosures. Again, this is meant for just general information purposes. I know that, again, some people in the room may be clients, but again, this is for just information, I'm not giving you medical advice. No doctor-patient relationship is formed through this video or anybody watching online. Again, I have no conflicts of interest with anybody involved here, so I have no financial interest with anything I talk about here moving forward, other than obviously my clinic. So, okay. So what is cancer? Again, we call it one disease, but really it's not one disease. Cancer has a lot of shared features, and so we lump it all together in sort of this family called cancer. But essentially, one of the main features is that it's uncontrolled cell growth. And what that means is that, all of our cells are constantly dividing and multiplying. And every organ has some level of cell turnover. Even this theory that the brain, for example, has no cell turnover is really not true. Every organ has some amount of cell turnover and some cell layer generally. So from that cell turnover, over a period of many, many years, sometimes the DNA copying kind of function that every cell has to do to become a new cell can go wrong. And then a variety of other things can really start to contribute to that. That can be inborn errors as well as things accrued over a lifetime. And then that leads to basically organ dysfunction and destruction. It can spread through the blood and other means to all over the body, and that's when it can really become deadly. So that's really what I mean by this uncontrolled cell growth and some of the kinds of general functions that are happening to allow these cells that would otherwise be healthy functioning, just skin, colon, prostate, cervix, etc., lung cells, right, that then all of a sudden become this cancer. So couple sort of features that we should all just think about when we think about cancer. Is it local or is it systemic? That's a really big mortality factor in cancer. And so when cancer is local, generally that means it's early and a lot more treatable. And once it's become a systemic disease, we have less and less treatments for that. And also just becomes more debilitating. So that's the main distinction there. And again, another distinction is kind of solid organ as well as blood origin. So our blood cells mostly are made in the bone marrow. So, kind of blood cancers are also maybe a bone marrow cancer. And then there's lymph nodes that go in that category as well, which are kind of an immune solid organ, but sort of special organ in between maybe. Solid organs really are any organ of the body from the skin all the way down to our internal organs. So any of these organs really can get cancer, though many of them are quite rare. So that's good. Again, local versus systemic. I put that twice, so that's a little typo. Oh well. Energy dysregulation. So basically, this just means that cancer has this feature that it doesn't use energy in the same way that the other cells do. It tends to try to use glucose first and make a lot of byproducts, something called the Warburg effect. So that's just kind of a common feature of cancer and ties into some ways that you could actually treat cancer. Hormone triggers, again, this is also just not that cancer is really caused by hormones, but many cancers, just like all cells in your body, have receptors that respond to hormones that are then going to maybe tell that cancer to grow even faster. So anyway, that also ties into treatment as well. And so again, not implying that cancer is caused by hormones so much as that it's involved in the development and growth of cancer. So this is just a diagram from a major medical journal about the shared characteristics of cancer. So here you can just see some of the things I'm trying to say in a little more common words. So basically, proliferative. So all of this kind of sums up to that the cell starts growing in a fashion that's basically uncontrollable by the other cells around it. So in normal kind of cell growth, there's signaling back and forth to other cells nearby. And, why wouldn't your, brain grow out of your skull when you're a baby? It grows pretty significantly as you grow older, right? Because it has this feedback from the pressure of the other cells in your skull that are telling it that okay, this is how big you need to grow, and other things like that in biology as these cells are kind of growing. It's really the neighbors, are important, and what those signals are coming in are important. So cancer starts to ignore those things, doesn't respond to those normal defense mechanisms we have within our own body to stop that cell growth. And these are some fancy scientific terms of how that's happening. So, why is this important? So I've tried to make my first few topics that we talked about here basically the most common causes of death. So cancer is number two as a larger category, kind of that umbrella category, and then we'll break it down by organ here. We'll see, and then not only is it number two, but I found this very interesting that if you look across age ranges, it ranks no worse than third among any age range. So really, this is not just a disease of the old. It really does, affect all of these age ranges. I don't talk about pediatric cancer here. That's something that, I just don't feel like I have enough expertise to necessarily talk about here. Some of the evaluation and things like that could double, for those cases as well. But again, I don't focus on that category much during this talk. So one of the unfortunate things is that, I really think that this is just not always preventable, right? I'm a very big preventative type of clinic. That's really what I'm trying to push forward and what I do. And that's really unfortunate in this particular disease because sometimes it's just not your fault, something you can control. Or sometimes it's, uncontrollable things in your environment, things you didn't know about. So, again, and that's what we know about now as far as, and we're discovering all sorts of new things about this as we go forward. So there's a high degree of variability. Again, I've mentioned that, that with cancer, even within a single organ, there's, lung cancer is not like another lung cancer. Prostate cancer is not like another prostate cancer. So again, that's unfortunate. And then even like I said, just the cancer category, while it has these shared features, there's so much differences between the different kinds of cancer. So that's that variability. And then here, this is just while there is a lot of innovation and a lot of really interesting things happening in the field of the science, right? A lot of these treatments and even the testing can really be pretty expensive. And so it's kind of just a high dollar area in medicine. And again, being as common as it is, I feel like we have some really cheap tools to deal with atherosclerosis and heart disease, which is the number one killer, and with cancer that, again, we'll see. But right now, a lot of this stuff, to really participate in all of it, I think would be sometimes cost prohibitive. So some risk factors here. Basically here, I didn't necessarily understand the question. I think, yes, I was atherosclerosis is ASCVD or yes, heart disease. I don't know if that was the question online. But risk factors here for cancer, really, there's not as many clear risk factors as there is with cancer as there are with many other diseases like heart disease, even dementia and a few other common diseases like that, diabetes, type 2. So, but here, we do see a little rise, definite rise with age. I think that just is a matter of time accruing some of these DNA damage kind of functions that end up causing cancer. So it's just a cumulative effect over time. Like let's say with like radiation, even injury and things like that, people who are radiologists or other, have had other exposures for other reasons. Um, Smoking tobacco, yes, we all know about that with lung cancer, huge, huge risk. And actually, it is for many, many cancers, but not all of them. And again, insulin resistance, obesity, these things are also pretty big risks for several cancers, multiple cancers all over the body, but not necessarily every single one of them. So I can't necessarily say there's some sort of umbrella risk factor for absolutely everything. But if you want to feel like you're doing everything you can do, I would say you try to avoid these things. Don't smoke or use nicotine, tobacco products. Don't develop, insulin resistance. Try to control your weight within a reasonable, metabolic health range. So, and then, some things we can't control, which are risks are, who are you born to? What's the cancer in your family look like? So obviously you don't control that, but plays a big deal, and that's through genetics, obviously DNA, as well as environmental toxins. So this is again kind of sometimes a controversial thing to bring up, but also something that I think there's good science behind. So again, this can be everything from air pollution to radon to secondhand smoke to even just chronic allergies and inflammation and other things of that nature. So this is a really big list that I definitely don't have all of memorized, but I think there's several things here that are playing a role. Cancer deaths. This is just a few charts. I don't want to be too kind of just data crazy, but I think it is useful to look at some of this. So this is just cancer deaths in the world, and lung cancer is number one, colon, another lower GI, number two, stomach, number three, which is a little different than the U.S. I don't believe stomach cancer is quite that high in the U.S. It ranks much lower. Breast cancer is very high in the U.S. as well. Esophageal, pancreatic, liver, prostate, leukemia. So again, just looking at how many deaths there are and what that proportion, all the way down at the bottom, we see testicular. So you can see that, again, even melanoma is kind of further down on that list. So some of those things are, still can be important and deadly, but not quite as common as, like I said, mostly lung, colon, breast, and then prostate, and we'll talk about cervical and a few of these a little more specifically as well.
Salivary glands are on their list. I can't see it.
So that would probably be like under like a head and neck or larynx. There's like a larynx, lip oral cavity. I don't know where that would be classified at under, so maybe lip oral cavity area. That's 208,000 in the world. So yeah, just above ovarian. So this is just not cancer deaths, but let's see if I can get this. I don't know what that is. Okay. Okay, great. I got you. Yeah, so the most common types of cancer in the U.S. This is not necessarily deaths. This is in the U.S. just common types of cancer. So you can see prostate's pretty high there, but it actually isn't one of the most common deaths of cancer. And breast is high as well, and it is one of the more common causes of death. Lung, you can see, is kind of in between there, pretty high, top what 3 or so, and but is one of the more, I think, is the most common cause of cancer death in the U.S. as well. So, and then colon, you can see there also pretty high, kind of in that top 5 range. So primary care, again, kind of what's my angle on what can I help people do? I think, again, if I can't prevent it, then hopefully I can catch it earlier if we are dealing with cancer. So why is that important? Here's just kind of a stark kind of numbers of why that's kind of concerning. Okay, so stage 1, you can see that survival rates are quite high, and then here, as you get to later stages, you can actually see how dramatically that drops off. So for breast cancer, we're looking at 100% sometimes, all the way down to 30. Colon cancer, we're looking at in the 80s and high 80s, basically, all the way down to single digits there at the 10-year survival rate, 1 versus 4. So really, again, early detection is super, super important, and I think it's something that sometimes really scares people. But what scares me more is honestly something like this, right? That knowing that if we had just kind of caught this a little bit earlier, that this would have been that dramatic a percentage chance. Again, I know that we can't be can have 9% cancer. Either you have it or you don't, and so we can't treat people like statistics. But again, this is what informs my decisions and my recommendations. So I just want to share that with people. So what are some of our screening tools? We'll talk about some that are guideline based and some that are definitely not guideline based. One of the big kind of differences there is also just who will pay for these tests. So many of them do have some decent data, but again, sometimes they do have a decent cost as well. So screening tests and tools. So again, guideline based, you can see here on this chart, breast, lung, cervical, and colon. I don't think anybody really debates these. There's pretty strong guidelines from the, one of our big bodies called the USPSTF, which is a big preventative task force that reviews all the preventative studies and data and sort of gives a recommendation for US providers of what we should be doing for folks in preventative standpoint. So for breast cancer, they do recommend that mammography at least every other year for the 40-year-old women going forward. And then really, again, there's kind of a separate recommendation there from the American Cancer Society where you can start to think about even yearly mammograms. So there's some flexibility here, but I do think getting a mammogram at some, maybe at least every other year interval seems to be the bare minimum, obviously by this recommendation. So personally, if women want to get a main mammogram annually, that's something that I definitely have a discussion with them about, and kind of, again, based on what they want to do and certain factors, I think that's definitely okay. Lung, here we have what's called a low dose CT. The low dose is just referring to less radiation, so that's what that low dose refers to. Still a better as reference to a full lung CT, basically. So again, they recommend 50 to 80 for people who basically smoke a certain amount, what's called 20 pack years, basically a pack a year for 20 years or equivalent, or a pack a day for 20 years or equivalent kind of amount of smoking. So again, here, that is the recommendation, but we also see kind of alongside this that lung cancer among non-smokers is rising. And so here, I think, we could have a risk-based kind of discussion. Cervical cancer, the bare minimum recommendation, again, is that women at 21 start having this every 3 years, and then after the age of 30 can start to space it with every 5 years. That's with kind of something called co-testing for HPV. The vast majority of cervical cancer is caused by HPV, so that's where that recommendation comes from. And then colon, again, that colonoscopy. So a few other things that I'm going to get into here and talk about each one of these more specifically for just a few minutes. We're going to break each one of these down and a few other cancers and kind of go into each one of those. Genetic testing. So these are, I didn't list all of the ones that are available here, but there are different types of genetic testing. Myriad is basically a genetic panel looking for certain genes that would make you a certain risk category for certain types of cancer. So it doesn't necessarily diagnose cancer, it just gives you a risk profile based on your genetics. And there's a couple tests in this vein. This is not the only company. They have, there's other, people that are doing things like this that have certain genes that have been identified to be higher risk for, let's say, pancreatic cancer and some of these other cancers that are deadly that we don't have any screening protocol for. Um, and then Gallery is a different type of test. That's something that's called a cell-free DNA test. This actually diagnoses active cancer. Basically, it's a blood draw. And it's sort of one of the terms called is a liquid biopsy. So basically, you get a blood draw and it can tell you if you have a cancer active in your body. Now, the problem with this test is that, well, not problem, but let's say considerations with this test are that it's quite expensive, around $900, $1,000 currently. I'm told that the price may come down. Also, we're looking at yearly blood draw is what they recommend after the age of 50. But again, and the other big consideration is that it is not as good at really early cancer. So stage 1 and 2, the numbers aren't quite as impressive as it is with some of the later stage cancers. But again, in a field where nothing like that exists, it's a tool concept and something that I hope will continue to kind of move forward and get better. Whole body MRI. So again, some of this stuff is definitely not insurance covered and sort of outside the fray of mainstream guidelines. So whole body MRI is definitely one of those things, and but again has some utility for again the right kind of person. Basically, it is a whole MRI of your entire body. They use certain protocol to kind of really have a good detection for especially solid organ cancers. These are looking at around $2,000. A lot of places that offer these, but it is something that again, it's cutting edge and doesn't really exist. Again, as far as my clients, they have the freedom to kind of discuss this with me. I don't know that many other offices and physicians are necessarily talking about some of this stuff. So again, whoever you want to talk about, or you can reach out to some of these people independently as well if someone listening is interested. So let's just talk a little bit about some of the organ-specific cancers. Again, I'm not a cancer doctor or really treat a lot of these things specifically, but I do just want to touch a little bit on some of these things. So lung cancer, again, we know tobacco smoke. I think that's pretty common knowledge by now. I think they're required to print it on all the products. And again, so chew is a risk for kind of the organs that it touches. So the way you can kind of think about it is the smoke, or if you're chewing tobacco or whatever that is, kind of all of the different organs that are involved in touching that, digesting that material. So it goes from the lungs kind of into the bloodstream. You urinate some of that out. So all of those areas are kind of affected. So that's one of the ways I kind of think about how is tobacco smoke or other tobacco products causing cancer. So again, the non-smoker category is very, very interesting, and that's where I mentioned things like environmental. If that's accounting for some of that, there's so many things here, whether maybe even pesticides and other things like that, and other waste products that are being washed into certain areas, sprayed into certain areas. That may be contributing to this. Again, I hope that we kind of can try to discover that if that's true. CT scanning is sort of what you can do. Again, I mentioned that low dose CT scan, 50 to 80 is kind of that recommendation. But again, if we are suspecting some of these exposures or other things like that, then that is the test that we have available to offer. Colon cancer. So this always starts from a colon polyp. Colon polyps arise from kind of the theme of cancers. A lot of it's from the glandular kind of more active turnover tissues of that organ. So colon is no different. Starts from a little polyp and then starts to mutate and grows into a colon cancer. Can start to really invade into the structures around it and then all over the body. Again, there are some links with maybe diet, microbiome, other things like, So on the both on the negative and on the positive, right? So protective factors might be things like spices, polyphenols, turmeric, and then basically, the other side of that may be a kind of what they call pro-inflammatory diet. So if you have a specific food allergy, or if you're just eating a lot of refined processed food, that seems to be driving up some of the rates of colon cancer, at least here in America. So again, so that's kind of that what we can do part. So there are some genetic kinds of colon cancer that are not super common, but very aggressive. So Lynch syndrome and there's a polyposis kind of syndrome. So these are some genetic things, kind of like BRCA genes and breast, cancer testing. That if you have a family history of colon cancer, especially very early, that was deadly, that you definitely want to check. Otherwise, if you don't have things like a really bad family history, or it was much later, kind of found colon cancer, 70s, 80s, things like that, then you probably fall under the normal guidelines of starting at 45 and having every, really, if it's normal, they say 10 years. Again, I kind of give a range there just because I like to be personal and like to talk to the patient directly and kind of develop a personal plan. But again, somewhere in that range, I think is a good place to think about 5 to 10 years. Certainly sooner if something is found and seen is precancerous or there's other concerns. So if the biopsies are taken, which again, so a note on biopsies, if we remove a colon polyp, and I said it starts from colon polyps, then that is actually thought to be preventative. So we do believe colonoscopy is to be the only preventative form of colon cancer screening. So the other forms are stool blood testing with or without DNA testing. Again, once you start to have some of these features, if you understand some of the pathogenesis of cancer that I just told you, you may understand that this might be kind of a later, cancer that's found with some of these tests. While again, if you're not doing a colonoscopy, I still order Cologuards, and they do have, good looking numbers on their testing. But they're, again, I just believe that a colonoscopy has some advantages over that and is safe. And actually, I offer that service for my clients. So that's kind of the talk just between that. Again, if you're not choosing colonoscopy, please choose something else to screen for colon cancer. Don't do nothing. And again, there are some nice tests for that through stool testing. And again, family history being important. Just a note on colon prep, what we do is actually just a mix of Miralax and Gatorade. So a lot of people are like, oh, the prep is terrible, this and that. Many of you may drink Gatorade already or take Miralax occasionally already. So it is a big load of those both in one day. So, but aside from that, it's not really as unpleasant as some of these preps have been in the past. And this prep we've been using actually works really pretty well. So pretty tolerable there for at least people involved in my clinic. Breast here. So again, one of the most common diagnosed cancers. So it does arise from the glandular tissue of the breast. So basically, as opposed to kind of the fatty tissue of the breast, so the glandular tissue is basically the tissue that was intended to make milk. And so those are basically kind of behind the nipple and a sort of a fray out from behind the nipple area, and all sort of have a connection to the nipple and areola. So that's basically the architecture of breast cancer and where it's arising from. There's some easy calculators that you can just click that link and go to type in some information that should be pretty easy for you to already know or find out pretty quickly. And things like, again, listed kind of here. So just about period, age you started your period, how many children have you had, a few other factors, family history, have you ever had a breast biopsy, some things like that is what goes into that risk calculator. So family history is important here as well. I mentioned that gene already, the BRCA gene, which many people have heard of. That's kind of that highest risk gene for several cancers in women, including breast, ovarian being another one. So definitely try to know some of your first degree relatives, especially, is what's important, probably the most important. Self-exam, again, this is a bit of a controversial topic. I just think that it's good to know your own body. And so I would very much promote women to, at least to be aware of their own body. Again, there are some normal changes, and I know that in some people this may kind of drive anxiety or fear or other things like that. And so I think that's the main consideration. Sometimes with self-exam or maybe over testing, things of that nature. But again, with those things aside, I just feel like if for the right woman, I think it's a good idea. Mammograms, I do think that, again, mammograms at every other year or so at 40, I really agree with that recommendation and would even be happy to be more aggressive for especially high-risk women. So I really give people the choice there to be more aggressive, either with mammogram or even adding things like ultrasound and MRI, which can be better for kind of dense breasts that have more glandular tissue, right? So that's what that means when you get that kind of finding. So again, ultrasound and MRI, adding those can be a part of breast cancer screening, even for in the right time cases, and certainly is a big part of breast cancer, like let's say lump follow-up. So even if it's benign, many times we'll get these tests to get better definition of what it is. And then we go all the way up to biopsy. Obviously, that's kind of the gold standard of diagnosing cancer. Pretty much in most organs, right? Is actually tissue is the issue, is what they say. So we got to get some of that tissue and then make sure that that's what it is. And then that also leads to very specific treatment routes. So an important part of diagnosing cancer. Cervical cancer here. So the cervix is sort of that exit of the uterus, the birth canal womb. So that is basically done by female exam, pelvic exam. So a little bit on the invasive side, I get that, but again, for a good reason. HPV is extremely common. Some of these studies have looked at HPV on college campuses, rates above 90%. So again, it's really not about some person that's very promiscuous or this or that. I mean, again, it could be one partner, kind of partners that have one other partner that, again, so it really doesn't take that much. And some of this is spread through other means, not just sex. So it's not always a sexually transmitted disease like that either. And that can lead to like head and neck cancers and other things of that nature. So HPV can cause cancer in other areas, but is the biggest burden of disease here in the cervix. So the recommendation for young women is to start at 21 with that screening, and then at 30, if everything's been normal, you can co-test for HPV and space that to every 5 years. So again, while that is sort of invasive, every 3 years, I feel like is pretty, not that often, especially to prevent something that's potentially deadly. And then there is some prevention here, right? So basically, there's a vaccine now for the deadliest forms of HPV. So, and that is recommended for boys and girls. So again, I know that there's a lot of personal feelings about vaccines, but this is a vaccine that exists, and you can get this. And I do believe that if you are vaccinated against HPV, that it lowers the chances dramatically of any of these cancers or even contracting HPV to begin with. Prostate here, so very common in men as you age, right? So kind of a saying is after 70, whatever decade you're in, that's what percent chance you might have prostate cancer. So 70%, 80%, 90% for those decades. So extremely common. Does not mean that you'll die from prostate cancer. So there's not a lot of really strong guideline-based screening here. We do have the PSA and AUA, the Urologic Association, does I think have a recommendation for the PSA. I personally will order PSAs on folks even yearly for the right men who are concerned. So while again this is not the most deadly cancer, it's super common. So you have to have that balance of sort of trying to find it and trying to understand it. So nowadays we have, I think everybody really, or a good urologist, let's say, really understands that and wouldn't recommend really aggressive treatments, even if you are diagnosed with kind of early non-aggressive prostate cancer, something called Gleason scores, which are kind of the guidelines there. that help them understand that. And that's through, obviously things like a biopsy as well as imaging like ultrasound and MRI. If indeed then PSA is rising or we have some concern on an exam like enlargement or nodulars kind of feeling to the prostate. And that exam again is unpleasant. That is through the rectum. So that is how I feel the prostate again through the rectum. So that's again unpleasant. But if there's concerns, I think that's an important thing to do. So I think that's all I have to say on that one. Some bloodborne cancers here. So leukemia, lymphoma, myeloma, other bone marrow cancers, or lymph cancers. This is a category I know probably not as much as some of these other, categories because there's not as much screening here. Basically, if you start to have some vague symptoms like fatigue, fevers, night sweats, other things like that, we start with basic blood counts and what's called a smear, where the pathologist looks at it and it looks kind of like this under the microscope. So this is how you can kind of tell, or a pathologist is specially trained to kind of tell whether you might be at risk for something like that or not. You can also get a test of immune proteins that really can help you understand whether you might be having, an active cancer of this kind or not. So this is kind of a difficult one, and certainly don't have any screening guidelines. I typically get, so this is kind of, many healthy people will say, why should I get labs? A CBC costs, I think, a little in the $2-3 range, let's say, and for my clients, and we're talking about, again, just screening for something that has no screening. So just getting a simple blood count, I think, I get some very basic labs on people. And while this is rare, hopefully in someone who's asymptomatic, that's the only kind of chance I have at catching something like that. Some of these other ones that are really difficult, and we really have nothing to guideline based to say anything, guide some of us on what to do, right? Pancreatic, ovarian, stomach, so many others. Basically, again, bone, like literally of the bone cells, right? You can have muscle cancers. I mean, you can have cancer of every single organ and brain, so some of these things are going to have organ specific symptoms. So if you notice a lump, if you notice some sort of change in function of something, some part of your body, and this goes back to kind of when I was talking about breast and self exams, right? This might be just true for your entire body, just knowing, what are your kind of daily patterns, from bowel movements to just how it feels to move and walk and sleep and eat and all of these other types of functions. Right. So if you're starting to notice some sort of difference, and pay attention and bring that up, right, and we can talk about screening for something specific. And again, we have a lot of tools to look at all sorts of different parts of the body, either from the inside or the outside. Ultrasound, endoscopy. I do actually now have a small ultrasound machine here in the office to take a quick look at things. Endoscopy, which is basically, the camera tests. I do that at the colon, not the upper stomach, but whole body MRI, which I believe there's going to be 1 or 2 facilities in the Denver area here in the next year or so. Gallery, which is that cell-free DNA testing, right? So that may be able to diagnose active cancer, whereas the other genetic testing, I didn't list that just because it's more risk, not an active diagnosis there. So I talked a lot about why screen for cancer, and I think it's fair to kind of mention why we shouldn't screen for cancer, or what are the risks with some of these screenings. And I think, again, one of the biggest ones is definitely false positives. So, you get a mammogram, there's some sort of lump or something, and now you need an ultrasound, or you get whatever a PSA and it's high, and now we have to at least get another PSA, or whatever test we get, right? There's different ways that looks. So whether that's, can sometimes all the way go lead up to a biopsy or some other disruption of that organ, surgery, right? And then all of a sudden you take out that thing and it wasn't a cancer. And again, while that's not like a huge percentage of what's going on, if you're that person, then that feels, I'm sure, very bad. So again, just thinking about that on the front end, that how far are you willing to go through this? What would that, could you live with some of that? Again, not super common, but it is something that can happen. And even just, let's say, if you have to get 2 more ultrasounds or 2 more labs over the next year, 3 more, 4 more, 6 more, right? Are you going to be okay with that? I mentioned complications from procedures, right? So again, I'd like to think that all of our medical providers are really trying to do the best as they can, but bodies being what they are, and people being so diverse, right? I mean, I think it's just the nature of trying to do some of these things for people, that you're going to have complications. And that can range from minor things like a minor infection that you take some antibiotics and maybe you're fine, or maybe you have some side effects from those antibiotics, right? Or it can go all the way up to really disrupting your life and changing, ultimately the function of an organ. Something like sexual dysfunction with the prostate, or colon perforation, where again, that may be life changing with a colon bag or some other things, which again isn't super common. That even 1 in 100,000, 3 in 100,000, right? That if you're that one, that's again not ideal. So again, thinking about just the anxiety, what is, are you going to be constantly worried, right? If and again, maybe that's something else, that a different conversation that we have, but just thinking about if we go forward with these tests, how much psychological stress is that going to put on you? Is it the right time in your life maybe to do that, right? So maybe just while I would, again, waiting can be dangerous again, but still, it's your decision, and you have to do what's right for you in that moment. And again, so that's a personal decision there. Again, some of these things are covered by insurance. Some of these things are not covered by insurance. Some of my clients have insurance, some of them don't, but we had to have some contracts to make some of this stuff a little more affordable, but not necessarily free. I mentioned some of them that are quite expensive. And then, you add the cost of follow-up testing, some other things like that. So it can add up. That doesn't mean it's not worth it. Cancer treatment can be millions of dollars a year. So just for comparison, a few $1,000s on some screening, I would say, and if you want to compare kind of the other side of it, I could say, again, some on the low end, you might look at $10,000 to $20,000 a year in some cancer medicines. On the high end, you might be looking at $1 million or more. So again, that's very, very realistic. So, and again, sometimes insurance covers that, and that's wonderful, and that's why you should, maybe think about an insurance policy. But again, that's just the cost right now. So mortality benefit. So this is kind of a big deal, right? A lot of studies haven't necessarily shown a mortality benefit with a lot of these screenings, and I don't have a great explanation for that, except that heart disease, diabetes, all these other things really kind of are risk factors for cancer even. And so perhaps something else then kills them after cancer, they survive a cancer and then they die of heart disease. Well, what really killed that person? I mean, it was both of those things very shortened their life significantly. So anyway, so that may be one possible explanation. Is just that there's a slew of chronic diseases, and then we sort of silo them off and say a person died of this, but then we don't look at the other 8 conditions that they had necessarily. So so that might be part of it. And again, I kind of mentioned this last one already. So are you willing to go through things like chemotherapy, radiation, which can be very destructive to the tissues nearby or everywhere in the body? And what is the cost of those treatments, and who's going to be paying for that? What are some of the treatments? Again, I don't go into like real specific details here, but we are looking at things like, small local solid tumor, take it out, right? Pretty easy. Skin, pretty easy to do that. Colon, we've talked about, even with some colon cancers, pretty easy to take some of those out early stages. So a lot of different organs here. So it can be as simple, as freezing a skin cancer in office, right? So So that surgery can look all the way up to kind of major organ removal, right, and life-changing surgery. So chemotherapy, basically, this is a large category of basically poisons that we inject into your body that basically they are poisoning cells that turn over quickly in different pathways. And so they selectively kill cancer cells, hopefully faster than other cells in your body. So that's kind of the general theme around chemotherapy. There's again, this is a big, big umbrella, and I'm not going to go into all the specific ones there, but just to understand that general theme of chemotherapy. Radiation, there's again very specific forms of radiation, and that technology has gotten really, really, I think, much more sophisticated and specific. But they can basically take different forms of radiation and blast a tumor in, basically wherever it is, and cause a lot of destruction through that radiation. So radiation again has that pathway of multiple cells multiplying, damaging DNA, and really allowing cancer cells to die faster than some of the cells around it because of that feature of cancer. So immunotherapy, this is actually changing your body's immune system in some way to actually then recognize the cancer. So immune invasion or evading the immune system is a major kind of feature of cancer cells. And so there are things like CAR T and checkpoint inhibitors that are out right now that treat different kinds of cancers, melanoma, myeloma, certain types, other types of cancer as well, that really are kind of revolutionary drugs and doing some things for people that really, there were no other treatment options. So that is, again, kind of different kinds of immune modulation. Checkpoint inhibitors kind of take the brakes off your immune system, allow your immune system to attack the cancer, but then that can also attack your own body a little bit. CRISPR basically is specific genetic modification that kind of modifies genes to specifically be able to detect cancer. This is more of a future kind of question mark kind of therapy. So this is, gene editing technology that, we might have really interesting treatments for here upcoming. So metabolics, basically saying what can we do, right, to modify certain things. So there's 3 bottles in there for him. Yeah. So basically there's, again, this is some stuff that doesn't have really strong evidence, but may have some certain pathways to even amplify some of these other treatment things. So keto, again, ketogenic diet may have some evidence to really boost certain types of cancer treatments. Nutrition, I think, is just important in general and really gives your other healthy cells the ability to continue functioning and maybe regain that healthy function. And maybe, again, like I said, the neighboring cells is super important in that concept in biology. So the healthier everything is, you have better reserve, you can really help withstand some of the cancer treatment. So even if nutrition isn't sort of treating the cancer, I just can't see how good nutrition, isn't important in prevention and on the treatment side. Exercise, I think there's really good evidence here that, this helps so many different functions in your body. Just again, that VO2 max measure kind of dropping all-cause mortality so dramatically, right? So death from all causes, there's very few things when you look at it that really does that. And so again, it's kind of, there is some limited evidence that exercise definitely reduces cancer risk as well. And then vitamin D, again, that's maybe through natural kind of exercising outside. There's kind of that correlation there. So don't get sunburned, basically, is kind of the message there. So. All right. So some of my references, again, many of you that come here know that I really, use Dr. Peter Attia's material a lot to develop some of my material and to kind of develop some of my concepts even. And then as well as kind of these major, preventative guidelines, Cancer Society of America, U.S. Preventive Service Guideline, the USPSTF mouthful. And then some charts from World and Data. Yeah, and this will go online as well. So if anybody missed anything, you can watch me on YouTube. Stop the recording.